I'm going to talk about something totally different because you heard all day today is lumbar, but I put in cervical today, okay? So now I have to figure out which one is go. Okay, disclosure, and a lot of the speakers here, distinguished speakers, they have a lot to disclose. I don't. It's in a way it's a failure, I guess. But anyway, I unfortunately have to mention some product's name here because it's the only one available in the market until a week ago. Okay, but I can assure you that the company unfortunately not paying me for mentioning their name. Okay, and so now why cervical is minimally invasive? You think about that. Actually, if you do a 1 level, 2 levels type of anterior cervical surgery, a lot of people here have experience. By definition, it's a minimally invasive. Small incision, you only cut the platysma muscle. That's it. There's no cutting of any muscle or whatsoever. And most are omohyo, which can sacrifice. And then it's all, you go through this. So by definition, for 1 level and 2 level ACDF, it's also minimally invasive. And nowadays, people actually send the patient home within 24 hours. I'm going to skip through all this because for experienced surgeons and also not that experienced surgeon will know all these are the indication to having to do an anterior cervical discectomy for decompression of the nerve or the spinal cord. And I'm going to, because I need to catch up the time. So ACDF, anterior cervical discectomy and fusion, is what we have been doing for over half a century. Okay, it's come out in the procedure came out in the 50s. So it's a well-established procedure and it works with good results, especially for 1 level. And the fusion rate is higher than 90%. Okay, and so this is what we very familiar with. Oh, what have I done now? Okay, but we also know that with more than half a century experience, the drawback of having a fusion in the neck is the adjacent segment problem. Because the level that fuse, you lost all the mobility and you therefore add more stress to the adjacent segment disease. Actually, it should not be a disease. Adjacent segment degeneration is a better use of term. It's not disease, right? So the incidence for having ACDF in young patients, usually because of trauma, and the rate of degeneration actually is the same as the old person having the same procedure. So it's not because of it's older people degenerate and also have an adjacent segment problem. Even for young people, they can also develop adjacent segment problem within a certain years. So it's telling you that the adjacent segment degeneration is the major disadvantage of having a fusion. Now I'm talking about 1 level fusion here only. So usually when we do a fusion, you use a cage or bone graft and a plate. And also because of the plate that caused the adjacent segment degeneration, and nowadays actually there's some publication to show that if the plate is right at the edge of the adjacent level disc, the degeneration is a lot more quicker and more prominent. So where you put the plate is actually very important. So because of the degeneration of the accelerated degeneration of the adjacent level, so reoperation rate is a lot higher for ACDF. Basically, for young people, within 10 years, you will see some degeneration and a big majority of them will end up having a surgery. So if you do a fusion for someone 60-something years old, which I consider them, they are young nowadays, easily they have another 10 years life expectancy, and by 70-something, they may need another surgery. So do not think doing a fusion to our patients is done. You have to think about how many years down the road for this patient. So I just want to advance this very quick. Then now, I just talk about one level. When you get to 2 levels, it's a lot more significant. The rate of pseudoarthrosis is a lot higher now. Okay, so the result is actually not as good at 1 level, and also the increased level of reoperation is even higher because now you fuse 2 segments. So the adjacent levels have more stress, and therefore they degenerate even quicker. Now, I'm not to mention about 3 levels, but I just want to focus on the 2 levels. So why are we doing this ACDF? Actually, the primary goal for the surgery is decompressions. We just want to free up the nerve and or the spinal cord to improve the neurological outcomes. We don't need to fuse. Okay, that's not our goal. Is not to fuse, but there's the technology available. Just like before artificial hip joints or knee joints, they fuse the joint because they have nothing better to available. Okay, but nowadays no one feels the hip joint and knee joint because of a degenerative hip or degenerative knee joint. So, so having a fusion, you can also put in the bone graft. You also can restore the alignment to make the leg more lordotic. Okay, but the thing is, all this also can be achieved by using artificial disc. Okay, you do it's the same thing. You have to decompress, but when you put the disc, you also can restore the alignment, restore the height, plus you also provide motion at the level of surgery, and therefore kind of protect the adjacent level. Now, the adjacent level will all still degenerate, but at a lateral rate of the degeneration of a human body is supposed to be. But it's not being accelerated and degenerate quicker because of the fusion. So now this is adjacent segment disease. This is a grading system for the degree of degeneration. So if you look at 2 levels, okay, because 2 levels is really the difference is significant. This is a study, an IDE study. You can see that, okay, for the adjacent level disease, based on the grading system, having 2 level fusion is a lot higher than using artificial disc. And also second surgery. End up the patient need another surgery down the road. Again, having 2 level fusions is a lot higher. It's very significant, higher than using artificial disc to preserve the motion of the 2 levels. Now, patient selection and indications. I have to say one thing is, some people may think artificial disc, the complication rate can be high, will come out, or the patient may not do well. I have to say one thing is, nothing wrong with the disc. If the disc get approved by FDA, go through all this clinical trial, there's nothing wrong with it. It's only something wrong with the surgeons. You either choose the wrong patient or technical error. Okay, now, throughout the talk today, you heard artificial disc is nothing new. Don't think that this is a new technology. It has been there for 10 years. Why not a lot of surgeons adopting it? Just like minimally invasive. I think a lot of surgeons is, I have to learn something new, kind of scared, and I'm comfortable with fusion. Okay, but if you think in the patient point of view, maybe this is not bad things. And now this procedure actually will become patient-driven. A lot of patients come to see me, they said, because they do not want fusion, they want to preserve the motion. So patient selection, okay, is very obvious that indication. This is an indication for doing the artificial disc. I want to focus on contraindication. Artificial disc is not to replace fusion, but artificial disc will serve only a population of patients that having a fusion will do better with artificial disc. We still do a lot of fusions. There's an indication for fusion. So there's contraindication of using artificial disc. So, for example, cervical instability. This patient needs a fusion. You don't want to preserve the motion for someone already have an unstable spine. Okay, osteoporosis, and now doing fusion actually is also contraindication, can be if the bone is too soft, but it's going to fail if you put in a prosthesis of artificial disc. Okay, and then infection, obviously, of course, significant cervical anatomical deformity. Artificial disc is for someone who have a severe cervical kyphosis. Those are not for artificial disc. Okay, allergy to the metals and to the plastic, and also the patient have a facet joint disease. The problem is from the facet joint. It makes no sense to replace the disc with to preserve the motion while the problem is actually at the facet joint. So now these are the patients example that you should not use artificial disc. For example, severe degeneration, spondylolisthesis. This patient need a decompressions and fusion. Or this case, again, kyphotic deformity, or the case at the right-hand side, the lamina is all gone. This patient actually have a cervical laminectomy, and later on the patient developed kyphotic change. We see that quite often, actually, laminectomy to decompress the spinal cord down the road. You can give patient this. Now, unfortunately, these patients probably need an anterior cervical fusion and posterior instrumentation, and this kind of patient should not have an artificial disc. So, talking about the history of disc replacement, okay, and in 2007 in America, okay, in Europe they have that sooner than us. We all know that. In America in 2007, the first disc, artificial disc, came out is Prestige by Medtronic, and you can look at the design. Actually, it's very rough, okay, metal to metal, like and then use 2 screws on top, 2 screws below. But Medtronic want to come in as the first disc to have the share of the market, the only one, monopolized. And they know that this is not the perfect one. Actually, they are making another one. It's going to come out later. It's called Prestige LP. LP stands for low profile. But at the same time, though, Synthos come up with a pole disc, and this you are going to see the pole disc from the cadaver lab later. Okay, so pole disc has become more common, and also Bryant disc come out later, but Bryant disc got bought out by Medtronic. It's seldom used in American, but it's very popular in out of America, and then come back many years later, but not that popular. Still not that popular in America. And then there's more discs come out in 2012, including like from Gobers, every spine company actually will come out with a disc, okay, artificial disc. And then Mobic C in 2012, and come out, they get approved for 1 level and also 2 levels. Okay, 2 levels because it's the very first disc that only FDA approved for 2 levels. That's the reason why when I mention a lot of 2-level artificial disc, I have to use the name because it's the only one until a week ago, on July 12th, FDA also approved Prestige LP for 2 levels. Okay, so now you have more than one choice. So, surgical technique, artificial disc actually, no matter what you use, what company of artificial disc that you use, it requires some technique. The surgeon must have a sense of carpentry. Doing fusion is very forgiving. Okay, you take away too much bone, you just put in a bigger graft, and it still feels, right? Artificial disc, the carpentry is really important. But is it a difficult technique? No, definitely not. The first couple of cases, you just have to be careful, you learn it, but after the first couple of cases, it will be just like an ACDF and type of case. I don't have addition time when I use the artificial disc. So again, this is a discectomy, just like you're doing an ACDF, and everything is the same. Now, don't forget, the goal is to decompress. Okay, so don't focus on the fusion or putting artificial disc and forget about the decompressions. The main purpose of the surgery is to decompress the spinal cord or decompress the nerve root. So after you do all this, and then you put in the the artificial disc. Now, every artificial disc available in the market, the way that they put in has some difference. Essentially the same, but have some differences. So whenever you pick up and want to learn a new technique, you have to know how to do it and do it right. Okay, as I said, if any failure, it's because either you pick the wrong patients or it's a surgical error. So I'm going to skip all this because I'm getting a signal that I'm running out of time. I'm using the next speaker times now. Okay, so I just want to very quickly to show some of the cases. So this is a very one level disc herniations, young person, 37 years old, beautiful looking neck. You want to fuse it? Okay, just if you fuse it, you know that by 47, this patient will come back for adjacent level. So this type of patient actually is a very perfect example to do the artificial disc. Now, artificial disc people will come out, they will auto-fusion, end up with a fusion, but that's technique. Number one is hemostasis. Number two is when you put the disc in, you see an anterior, posterior, there's no room for hectopic ossification. Okay, so you don't put a small one, it's easier to put in. You have to do it the right way. As I said, technically, you have to think about all this to prevent a hectopic ossification. So this is flexion extension, you can see that. And then this is a 2 levels. Now this is patient have a kyphotic change due to degeneration, 2 levels, 4, 5, and 5, 6. And then this is the X-ray, and this is the baseline data before the surgery. This is there's improvement clinical result. Now I want to show it to you that there's a significant decrease in the disc height, and so if you put artificial disc, you can restore the disc height too without destroying the end plate or whatsoever. You can still jack it up and put in the artificial disc. And the one thing is for the midline. Now you will learn about the midline today. When you put artificial disc, you have to put it right. You don't want to put it on more towards right or left, in the middle. Now, so some people will use the spinous process as the midline. Don't do that. It's not accurate. If the patient during the surgery, the head turn a little bit, the spinous process will shift. You use the joint, the 2 uncovertebral joint. When you're doing the dissection, you can see the 2 uncovertebral joints, and then you can tell where is the midline. Okay, so you don't even actually need to take another AP X-ray to mark where's the midline. That's what I did when I first started using artificial disc, maybe about 10 years ago. But later on, when you accumulate experience and you look at that uncovertebral joint, then you know where's the midline. So you can see that this is right situated right at the middle. So this is talking about the adjacent level, and now 6 weeks after that, you see the C3-4, and then 4 years later, C3-4, there's no significant increase after 4 years. Okay, if you use a 2 level, you preserve the motions, you see the adjacent level, there's the advantage of preserving the motion. This is a football player, NFL player, so the neck is really huge. Okay, and I just want to show, and this patient is lifting weight, and then suddenly lost the function of the right arm is so weak. So we decompress that, and this patient is big. By the way, he's on steroid too, and he admits, okay, he's on steroid. So this is the biggest disc that I use already. So I still have no room. I still have some room at the back. Usually I want to eliminate that, but I don't have a bigger disc. But this is more exception than normal, okay? But I think this case kind of interesting. So that's why I put here. So this is it's a 44 years old Microsoft, it's a small lady now this time. Now this is a perfect example using artificial disc. The patient have a disc herniation at 3-4 and then 5-6, 4-5 is totally normal. Okay, if you fuse 3-4 and 5-6, 4-5 is going to go very quick. Okay, so this is a perfect example, perfect indication of why you want to preserve the motion at the level of 3-4 and 5-6. And so this is what I did to her. And then this is against a young guy, have a previous fusion at 3-4-4-5 because he ice hockeys. Okay, it's trauma. Now, so that was quite a few years ago. By age 38, you know that the adjacent level is going to degenerate. So now he has problem at 5, 6, and 6, 7. Okay, so instead of 38 years old giving a 4-level cervical fusion, if I need to extend it down, so I give it a artificial disc at the 2 lower levels. This patient is 37 years old, 3 levels problem after slip on the trampoline. This guy do all the research and come to see me and want 3-level artificial disc. And say, no, I can't do that. Okay, only allow 2 levels. Then I'm going to go to Europe. I say, okay, fine, you go to Europe, because I still cannot do that. Okay, so Europe can, in France, they do 4-level artificial disc, by the way. And so at the end, after he think about all this, so he said, okay, fine. So I end up doing 2 levels artificial disc and 1-level fusion. Okay, now, which level should fuse? There's no data. Is it should be a top level, middle level, or the lower level? There's no data. But I think usually we see the upper level degenerate quicker, okay, after fusion. So that's the reason why I put it the lowest level and upper 2 levels use the artificial disc. And this is, people say artificial disc should not be used if it's a spinal cord compressions. This patient, obviously, you can see it's a myelopathic problem. And you can still go in and decompress. Just like you do an ACDF, instead of put a bone graft, you put an artificial disc. By the way, this patient also has a big bone. Okay, so it's a bigger disc I have, you still can see some room at the front. But usually I put the disc as posterior as possible. At the front, I can control the bleeding. I can put bone wax. And so it reduce the chance of head-topic ossification. And I don't allow to roam at the back to fuse, and they can compress on the spinal cord. So this is an example of technical error, okay, and by the way, it's not my case, okay, so it's my IDE. Okay, so far I have no patient that I need to remove the disc. Okay, so this patient have C4-5, C5-6. Okay, you notice that at C5-6, actually the posterior part of the vertebral body get removed too much. The burr, and therefore, when they put a disc in, it's already, it's immediate post-op. This is already kind of falling off. Okay, so you can see that's supposed to be parallel. So there's too much bone has been removed, so it's not able to anchor on the disc. So the disc slip backward. Even though the patient at that time still asymptomatic, but it's risky because the spinal cord is right there. So they take it out and convert it to a fusion. Okay, and then the disc above at 4-5 does not look that great either because, again, this is some technical error there, but it's not giving any problem. So just leave it there.